Service Implementation Simulator aims to create a virtual model of the service based on given characteristics. This means each of the pilot regions now have the possibility to build a simulation of the services based on their own local situation. The assistant tool may generate a suitable way of using ICT, and not just in a specific region, but for each individual patient as well.
And that lesson is called "Sorry, I'm Out." And that's something I think I encountered this first in the first integrated care project that I was involved in, Commonwealth. You have a constellation, service scenarios where a lot of different stakeholders are involved, and you change then you start changing how these people work. You shift responsibilities, you shift tasks, you shift funding, and what is very likely to happen is that some stakeholders will lose because of the changes you want to put into place. That can be very different. Why this happened, how exactly this happened, depending on how the service is set up, and also depending on how the reimbursement system works, of course. Losses that may happen can be money, so there's actually less income because of the change that has been put into place, but it can also concern staff time, so people have to work a lot more. Suddenly you have this huge electronic patient record where everyone has to put in information, and that takes a lot more time compared to before. But it can also be intangible factors like image, so that a doctor says, I'm not seeing my patient anymore. He thinks I'm not caring for him anymore. Or it might be power struggles. That's saying I'm losing influence within the health system. So there's a lot of things that people can lose when you put such a complex service into place. I mean, if you look at a situation like we have here in the service scenario with some 7 or 8 stakeholders, you could always say, okay, one stakeholder loses, too bad, but that's the problem of that stakeholder. It's not the problem of the overall service. And then it depends a bit on the position that that stakeholder is in. Will he just be saying, okay, do that without me, I'm leaving? Or is that stakeholder maybe actually in a position to jeopardize the whole service idea, to prevent you from putting the new service into place? Just to give you an example here from Germany, and I guess it's quite similar in most countries. In Germany, GPs have quite a powerful position within the healthcare system. And as you may know or may not know, that we have been trying to introduce an electronic health insurance card in Germany. So an electronic card with an electronic patient file linked to that card or stored on that card. And I think that has been going on for 10, 15 years, and it's not happening. And one main reason for that is that the GPs are not convinced that it is good for them, because it introduces a high amount of transparency into healthcare and a high amount of transparency into the reimbursement processes that might actually lead to reduced incomes for the GPs. And now the GPs have a very powerful lobby in Germany, and so they're actually in a position to prevent the introduction of the electronic health insurance card, to make the story a bit simple. But that's just one of the examples. You might have stakeholders in a service that are losing out, but you cannot afford them to lose because they might stop everything that you are doing. Now, let's go back into the tool. And let's start looking at the GP. I mean, I explained a bit about the GP already, and if you look at the HPO-PCO sheet, that's the GP.
Which one? GP?
HPO-PCO, Primary Care Organization.
Yes.
And from what you know about how the tool works, you should be able, I think, to see what the GP's attitude towards this new service is. Would the GP be in favor of this new service idea or not?
Probably not, because he's losing money.
I know what.
Yeah.
Not only losing money in this case, but not necessarily money that's included. The assist tool includes all factors that are impacting. So it can be also time that the GP is losing. So maybe it takes more time to treat the patient, to write something up, or it can be simply his feeling that's included here. So intangible factors.
Yeah.
Intangible factors, I think, are not part of this example, but could be.
Yeah. But again, yeah, there is this minus in front of the number, and then if we're going to the chart sheet again, and we select the primary care organizations for the, you can see, yeah, the same expressed as a graph. What might be interesting, as Rainer said, the socioeconomic return includes money, resources, and intangibles. But even if you're looking only at the cumulative net benefit, and that's concerned with money and resources, select the primary care organization. There. It looks even worse, because the line just keeps plunging. The cumulative loss amounts to some 400,000 euro within a 7-year time span. So that's a bit the order of magnitude of the problem. Do you remember from when I explained about the GP what the reason is for this loss in income?
Because in Germany you pay on per treatment basis.
Yeah.
But in Bulgaria it's a lump sum per capita they are paid.
Ah, okay, yeah. So they would, you would not even have that problem,
Yes.
probably.
You would have others.
Have a problem of the GP being paid despite the work he's doing or not doing.
Yeah.
Yeah, but here, I mean, you probably remember part of this early support discharge program. The immediate patient follow-up is now being done by the social care provider and no longer by the GP. So the patient is coming into the practice less, the GP is getting reimbursed less. And you can see this here if I'm back on the HPO-PCO sheet and scrolling down to line 250 and 260. Foregone income, so a loss due to avoided practice consultations and due to avoided home visits. You can see that for a practice consultation, the GP would get per consultation 100 euro, and for a home visit, per home visit 120 euros. So he gets a little extra for the traveling. And on average, patients come see him 4 times less than before, and he goes out 2 times less per patient to their homes. And you can see in the sum, this is a big loss of income. So now we have here a GP, and that's a German-style GP, so his position in the system is as powerful as I've described. So basically, one would have to find a way to improve the business case for the GP practice, because otherwise there would be a danger that the entire service fails, because the GP would start giving television interviews and telling the nation what a bad idea that is. Again, it's a similar problem, but we cannot apply the same solution. So we cannot make the hardware cheaper, and there's also no fee being paid to the GP. So do you have any ideas what could be done instead?
We can introduce some extra income for the GP for patients who use telecare, but who's going to pay, I don't know.
Yeah. The question is where that money would come from.
Yes.
I mean, you could print it in the cellar, but that would probably cause some problems on the other end. Where is money being, not generated, but being saved? That's maybe a place to look. You may remember that the early supported discharge program
Yes.
leads to avoidance in hospital readmissions and to reduced bed days. So I'm going back to the chart sheet now and stay here with the cumulative net benefit figure. Let the GP selected for the left-hand figure, but on the right-hand figure I select the hospital. And that's a nice looking figure for any economist. The line goes straight through the roof. It crosses zero after a year. And that's exactly the immediate benefits from the freed hospital beds and from the avoided readmissions that are currently staying within the hospital budget, because we have, up to now we have assumed the hospital budget is not being changed, so they are reaping this benefit. But that might of course be a way to, so to say, pump some of this money back to the GP.
So the money is there, but it just doesn't end up in the right stakeholder.
What we can do, I'm going back to the HPO PCO sheet, and there is in line 550 an indicator that is exactly for this kind of benefits, that's called top-up payments from health and social care payers. I switched that on. And that's an amount of euro per patient per month. Maybe I have no idea what it should be, but maybe if we start with 100 euro or something to see what happens. Oh, okay, I know that's probably a bit too much.
2 million.
2 million
per month per patient.
Yeah, maybe we go back to 25 euro, then we would be in the.
Yes.
So see, the hospital figure does not change because we have not adapted the hospital, but look at the GP, and that's looking okay now. So he's actually, because of this top-up payment, able to make a profit from this. So that's the immediate solution of the problem, but in reality it is of course a bit trickier. Because if one of the goals of integration is to save money to the system, you cannot just keep pumping the money around, because then you will not make any savings.
We need to check whether the whole efficiency has increased.
Yeah. So one other ways would be to I don't know, maybe you could limit the amount of visits done by the social care provider, or introduce a kind of minimum amount of visits to the GP practice. Things like that. But you get into some nitty-gritty fine-tuning. because actually in this scenario there's not so much money being saved on the whole. You can push it around, you can push it from the GP to the social care provider because the social care provider staff is cheaper. But if you want to resolve these kind of problems, it might actually become difficult. Yeah, right.
What is the overall efficiency telling us? That's also something you can see in the tool. So for all stakeholders now, is the business case still there? So is the service more efficient? And that's what this graph is showing you down here. So currently it's still over 20%, and I think that's pretty good for such a service if it's overall 20% more efficient than it was before.
Yeah.
So actually we can pay the GP 25 euros per patient a month because we're saving somewhere else a lot of money.
Or producing a lot of effects.
Yeah.
Yeah, because this is again socioeconomic return. So that also includes, for example, the health outcomes for the patients, and something we have not looked at.
That's true. Yeah. So this is not showing the money, that's showing the overall result. So we would need to look into if it has a business case.
Yeah. But I think what you said, the important thing is this is a kind of control. If you keep on pushing around within the stakeholders or between individual stakeholders, you keep an eye on the overall return to see whether the whole service still makes sense or not. Okay, do you have any questions about this?
About this one, but I have a question about the sheets. In PCO, for example, on the top left-hand side, there are a couple of tabs. The active one is notes, isn't it?
Where are you now? Sorry, I did not hear that.
On HPO, PCO, for example, and on the top left in cell 1, it says this sheet, hello, notes, time series, and admin. What do we use them for?
Yeah, good point. Maybe you just click, the first one is help. If you click on that one, you will see more things than you did before. So basically here, there's a number of columns that include help text for each indicator.
Okay.
So for example now, for extra staff time for service provision, there's a general explanation what is meant by the indicator. And then for each variable, there is also some hints as to how this can be measured and how the data needs to be put into the tool.
Okay.
And then you can, if you don't, as long as you don't need it, you can switch it off again.
This is simply to save space and make it not look as crowded. So if you want to have a tidied up view.
The notes is usually activated. I mean, if you click on that, you're seeing even less columns. But if you switch it on again, notes are these gray boxes here. And that's a bit of workflow management for the indicator. You can note for each variable, where does the data come from? Who is in charge of collecting the data? When does it have to be collected? And you can make any notes about things you still have to do or that might explain where the data come from and so on. And we have this workflow management here that allows you to say, okay, what is the status of the indicator in terms of the setting up and data collection? In the beginning, you maybe start, okay, I'm not clear whether we will need this indicator, so the status is unclear and it's marked in red. The indicator is clear, but I don't have any data yet, so the status is no data and it's marked in orange. Or everything's fine. I have some preliminary data put in, but it's not the final data yet, so it's marked in yellow. And then finally, everything is okay. All the work is done. You set it to finalize, and it becomes green. So yeah, a little workflow management, if you so will. And that's within in the notes section.
And then we have the time series, and that includes all the calculations. So if you want to see in more detail how actually all the figures are calculated over time, you can see also all the monthly results, these calculations.
And that gives you a lot of columns, and each column is 1 month of those 7 years. And then you see here the actual amount for that month. For most of the things that might be a bit too much detail, but sometimes, especially if you want to see the figures that are behind the graph, that can be used. And then we have admin.
That's actually only for us. That's to administer the tool, and there's some hidden things for the functionality, so it's not important for you as a user.
Yeah. So those are the 4 buttons there.
Yeah.
And the other settings and stakeholders are just navigation, so that would take you straight to the settings sheet or to the stakeholder sheet.